This is LiveWell Talk on Multi-System Inflammatory Syndrome in children. I'm Dr. Dustin Arnold, Chief Medical Officer at UnityPoint Health, St. Luke's Hospital. Multi-System Inflammatory Syndrome in children has been a trending topic of late, as the condition may be linked to COVID-19 infection or exposure in children. Joining me to talk more about this today is Dr. Dilli Bhurtel from UnityPoint Clinic Pediatric Cardiology. Welcome.
Thank you. Thank you for having me here.
Let's start off with what this condition is, multi-system inflammatory syndrome in children. Just walk us through what's going on.
So exactly, this condition involves is the post-infectious process. After certain infection, now we're thinking this is related to the novel coronavirus infection. After the infection is done, the body produces the immune response, and now this immune response is affecting, the immunity is affecting their own body, especially in children, which is affecting multiple organs. That's why we're calling multi-system. It involves abdomen, it involves their skin, it involves their heart and their brain and brain system. So this multi-system involvement, it makes them very sick. And initially that we were confusing this with whether it is a Kawasaki-like illness. And that's where the alert came up from United Kingdom around April 27th, saying that, hey, we're seeing the kids like Kawasaki, but that they are not really fitting the criteria of Kawasaki illness. They are more sick and they are behaving like toxic shock syndrome kids. So they were like, yeah, this is a new trend coming up, but this is not right. Hey guys, keep an eye on it. Look around. So they alerted us around there. Then by May 2nd, our colleague around East Coast already started seeing the same trend. And they came up with like, yeah, we're seeing the same. They're not fitting the criteria for Kawasaki illness. So they have definitely different trend. And they are showing some features of Kawasaki, but they're having other features which are not linked to Kawasaki. That's what we've been seeing these days.
So on Kawasaki, I always remember Kawasaki motorcycles. So Kawasaki, M starts with motorcycle.
Yeah.
And it affects the medium-sized blood vessels.
Yes.
Is that the same with multi-system inflammatories? It's medium blood vessels?
So we don't know much about it.
Okay.
We have seen some of the kids with already involving these medium-sized vessels and coronary arteries. And what we are seeing more in mystery is involvement of the myocardium and myocarditis. The heart function gets depressed so quickly that that was not seen in typical Kawasaki disease. Less than 5% of the Kawasaki disease, which end up having Kawasaki syndrome, we have seen such scenarios, but not on typical classical Kawasaki disease. To really make it very simple, I think we can discuss what is Kawasaki, and how it's related and how it is different. So
let's start with that.
Yeah. So the Kawasaki disease, as we know, is almost like known to us for the last 50 years. And it's a febrile illness. Children present with fever, usually typically less than 5 years old children. And we know that around our catchment population, we see around 6 to 7 children a year. Fever for 5 days is a classical presentation. Then they have pink or red eyes, rash of any kind involving from face to whole body. And they get these lips and oral cavity changes is because of their mucus involvement. And they have interesting peculiar hand and extremity swellings and the lymph node swelling in the neck. So if you have a fever for 5 days or more, and then you have 4 of the criteria that we just talked, then we put them as Kawasaki disease, typical Kawasaki disease. We need to have that, oh yeah, we don't have any plausible diagnosis for these findings, and we don't have any blood test to confirm or refute Kawasaki. So it's been a challenge even to diagnose Kawasaki in children. Thankfully, it's not that common. It's rare. And our colleague and we are very aware of this condition, and we're picking up 6 to 7, 8 cases a year, and we've been diagnosing and managing them. Now with the MISC, multi-systemic inflammatory syndrome in children, what we're saying is they may not need to have fever for 5 days. That's a little different, that they appear sick. They have fever, which is 38 and above. It could be just for 24 hours. CDC has just come up with this definition. Hey, we don't need the fever for 5 days. It's different than Kawasaki. may have just 24 hours of fever, but they have these abdominal symptoms, like abdominal pain, vomiting, diarrhea, and they are lethargic and tired. That's alerting people. And obviously, also they have this skin manifestation, pink eye, and any type of rash has been described, with being very lethargic, tired, pink rash, that's causing already more than 2 system involvement. And the clue here is that inflammatory markers, that the blood test that would show significant elevation of these inflammatory markers. When we put these things together, like the febrile illness, elevation of the inflammatory markers, and this clinical constellation of symptoms in a child who has recent contact or recent diagnosis of COVID-19, then we're saying that, okay, this is MIS-C, multi-inflammatory syndrome in children. That is the difference between Kawasaki and MIS-C. You may not see rash in MIS-C. You may be seeing more of the abdominal symptoms, which you do not see in Kawasaki disease. And we do not want to wait for 3 or 4 or 5 days if we have this kid is not looking well. So we have to be on a high alert situation, high index of suspicion, so that we're taking care of these children early before they get very sick.
I think even in adults, which is my specialty, of course, but in children, fever, rash, it can be something very serious.
Yes.
That's something you do not neglect, a fever and a rash.
Absolutely.
In any patient. Is Kawasaki's disease associated with any sort of prodromal exposure and infection?
So there have been lots of hypotheses, right, and lots of research going on. It's been thought about any 3 to 4 weeks earlier viral infections or that trigger, and some children shows that hyperimmune response to that infection. That theory has been there. So we've not yet found the real link, but we know that it is, again, the same immune response to our body.
Now, once we make the diagnosis and we've excluded bad things, Rocky Mountain spotted fever, meningococcemia, things along those lines, what is the treatment?
So, yes, the treatment is like Kawasaki, MIS-C is being treated with the immunoglobulins and steroids. So the response to immunoglobulin has been pretty good, and adjunctive steroid therapy has been really advocated. They appear sick, MIS-C kids, and they're getting both IVIG and steroids. But we have to stratify. Invariably, everyone is getting IVIG in the case studies that's been published, as well as unpublished data that I've been talking with my colleague in New York. They've been using IVIG for almost everyone. Then the adding steroids depends on how sick that kid appears on presentation.
Now, how this is a question as an adult critical care physician. Steroids, I love steroids. I'm trained in the generation that you just give everybody steroids. But, we know there are side effects. Do children do well with steroids? Do they tolerate well, or do they develop the same stuff that adults get?
Yeah, they do tolerate pretty well.
Okay.
They do tolerate pretty well. And then dose is very short course, We do either the pulse steroid or 3 days, Q12. And we're not giving more than 1 gram, so like 2 milligram per kg. That's how the doses have been, So it's a pretty relatively lower dose. And even if we need to do the pulse doses for 2 to 3 days, then they do respond very well. And the experience we've been tapering pretty quick. Once that's, if they had to be on 5 to 7 days, then we don't really need to give them longer than 5-7 days to taper.
And so you're following laboratory work, the markers of inflammation, and the clinical appearance of the child.
Absolutely. Okay. So this is a very, as we do not know much about this condition,
right.
MIS-C. Prior to this, we were taking care of fever, we wait for 5 days, right? Oh, they have rash. As you mentioned, that rash and fever, we always worry about them, right? But not typically MIS-C kids may not have rash. So what is really the determining for us would be the lab markers, when we do draw the labs, that will help us. And there are specific labs that we're not just doing the CBC and CRP, we're asking for more labs, ferritin, D-dimer, fibrinogen, and then LDH, interleukin 1, or 6. And then we're adding the troponin, BNP, to look into the cardiac markers. So that those inflammatory markers will really help us to determine, okay, this is not our typical Kawasaki.
So what, as a parent, if I have a child, first of all, when you say children, is that up to the age of 18, 21, or is it less than 5? I mean,
basically, this with the MISC, it's affecting children a little older, like 5 to 15, 16, that has been common.
Okay.
Not that they are also affecting children less than 5 years. Typically in Kawasaki, we see children less than 5 years of age. However, MISC is affecting children a little in the older age group. Even with the New York data, they are getting that, around 1/3 of children are less than 5 years of age. In Kawasaki, to see that atypical group having more than 5 years is very rare. So that really determines us like, okay, if a child presents with like Kawasaki, but is the older age group, 6, 7, 8, 9, 10, 11, then we think like, okay, this is potentially a MISC.
Well, I think this sets up what we're seeing with the children and is such as the hypothesis. So parvovirus, slap cheek in children, very common, very easy to diagnose. But I've always had this theory, adults will get parvovirus, but it's more fever, no rash, arthralgias. And it's just a viral illness. You could get the parvovirus titer and it's going to be there. Or, yeah, my children are home from daycare. And, so they react differently. We've had these case reports of people saying, oh, they got COVID-19 a second time, 4 weeks later. What may be happening is they're having some sort of post-viral immune response. The viral titer, the COVID, the positivity, the PCR is just, it's not infectious. It's just some people are carrying it long. We know some people, case reports up to 37 days. So that kind of sets up a hypothesis that might be what we're seeing.
Absolutely. Absolutely. I agree with you that, on the 8 cases that they've been reported from UK, they've been PCR and antibody. If you look at that, one kid has both PCR and antibody positive, but most of them has only the antibody positive. And the 10 cases from Italy, the similar picture, they were saying the antibody positive. So it's rather than the recurrence of the COVID, it is a post-infectious process that these kids are getting really sick and getting admitted. So the publication from New York, again, that the 37 kids that were admitted, you're absolutely right. They had 13 ICU admission on that case series, and I suspect that might be the case. So rather than the primary novel coronavirus infection, post-infectious process was already starting on those kids.
So as a parent, you should just be suspicious if your kid has lethargy and a fever and is not feeling well in this day and age, and contact physician. There's really no question there. I mean,
absolutely.
You need to pull the trigger.
Absolutely. The basically our ask is not to have a high threshold. Some of us are like have so much high threshold to go to the doctor, right? It's a common illness. Here we are asking like have a low threshold, be aware, do not panic, be aware of this condition, which is still rare, but be aware and seek help with your doctor, your child's doctor, contact with them sooner than later.
And parents would also ask this question, my child has it, we get out of the hospital, they recover. When can they go back to normal activity?
Absolutely. With the MISC, once they infect this process, the child is back to normal self, they can go back to straight away.
Okay. Well, that's good. Yeah. That's reassuring. Yeah. The summer activities start.
So you might wonder that, how do you know? Because this is very new condition. What we are extrapolating the data from the Kawasaki, So the Kawasaki kids, we said them go back when they are fever-free and then they're good to go. When there's no cardiac involvement, they're good to go. So we use the same principle in this case.
I find, Dr. Bhurtel, this is interesting. We have the intensivists as well have friends that were in New York that they used as a resource and they exchanged information. Sounds like you did the same. But we've also been a victim of that quick information exchange. China wasn't as transparent as they probably should have been. We made extrapolations based on what we saw in China, which ended up being wrong. Italy got overwhelmed. We made so you've seen both the positive and the negative influence of rapid exchange of information. Where before the internet, before 24-hour cable news, before all, there would be time for that to settle out before it's moved on to the next. People say, hey, here's what works, here doesn't work.
Yeah. That's amazing that you brought that up. I was gonna come to that in a way. If we look at when on April 27th, right, in UK they alerted. Italy has seen way more cases than UK, way before them. By March 16 to end of April, Italy has 10 cases on that same area, but they didn't report it. that time because they didn't know. They were just treating us like, okay, this is like a Kawasaki disease.
Yeah.
And May 6th, the paper from UK published with 8 cases. Then Italy's put up together and published on May 13th, next week. Hey, we have seen the similar illness.
Yeah.
So we were really in advantage here that in our colleagues in New York were saying, yes, we are also seeing, we have a largest series here. The center that I worked in New York, I trained there. My mentors are publishing the largest series so far, going to be published soon. So I was getting those information and that makes real sense. So I was so prepared, we were prepared, along our colleagues that we're sharing this information and that made us like, we're not making this journey for the first time. It appeared we're treating our first case in Iowa, but it didn't even feel like we were treating with the first case. It felt like we were dealing with, as a team, it was 103rd case that we were treating. So it was amazing. We got hit by the coronavirus later than East Coast, but we had lots of information sharing, So
on our side of the street, over in the adult intensive care, we were here in China and Italy just because they were overwhelmed. You need to put them on mechanical ventilation, intubate them right away. You need to convert your anesthesia machines to ventilators, which is not an easy thing to do. But then New York kind of started that route. Then they started using non-invasive ventilation, and the patients were actually doing better.
Yes.
And then we found that maybe the interleukin 6 inhibitor will keep them off the vent. Let's try that.
Yeah.
We've learned so much.
Yeah.
I know sometimes people get frustrated. We don't have enough testing. We don't have enough this.
Yeah.
This was just 60 days ago.
Yes.
I mean,
absolutely.
That's amazing.
Yeah. That's really amazing. If we think about our new condition, MISC, which is literally put the name by CDC on 14th of May. So we're like 3 weeks into this.
Right.
And we already know these kids really, if we pick them early and treat them early, they don't need to get to ICU. And if they are not, then they end up having this going to the ICU. And these kids, less than 1/3, even they don't need even respiratory support. This is very interesting on going back to talk about MISC.
Well, and I think people have no grasp of if we do get this vaccine within a year, that's unheard of. I mean, that is just amazing.
Yeah.
And I've said on other podcasts, I'm not very optimistic just in the fact that coronaviruses tend to mutate and it's hard to have a vaccination for them. But, I'm hoping. This is great information, and maybe we'll have you back in a couple weeks or so as something changes and we have some more definitive, have kind of a multi-inflammatory syndrome part 2.
Yeah, absolutely. I would love to. And we are really working with our colleague around and sharing the information. And as UnityPoint has, as a region, has already sent this communication throughout our primary providers. Everyone is really alert,
Yeah, so that yesterday came out.
Absolutely. We're working very well, and communicating. As we hear, we are communicating this information. So we are well prepared. And this is a set example that we're so prepared. When we had the first kid entered through our emergency department, we knew what it was. That's how we, we're very privileged to have this.
Question before we say goodbye here is, why pediatric cardiology?
So that's...
everyone gets this question.
So basically, during pediatric cardiology I was fascinated with children from my medical college years, when I was taking care. Then so fascinating that the way their recovery is, the way that once you repair their defect, and they're like back to self, so quickly. And that gives such an immense pleasure to the family, the parents that you see.
Absolutely.
That you won't get anywhere. That's how I feel.
I remember my daughter's young, they'd have a fever, just a viral illness. You give them acetaminophen and they're climbing the curtains.
Yes.
Like 30 minutes later. They went from lethargy, prostration to, rambunctiousness.
Yeah, that's amazing. That's really amazing, the way they turn over, right? So quick.
Yeah.
And that immense pleasure to the parents and grandparents close to them, and they come with that biggest smile, and that drives you. That's that's amazing.
Well, we're glad you're here. We're glad you joined our medical community. Is it 2-3 years now?
Close to 3 years now. Next month.
Time goes fast. Really great information today. Again, that was Dr. Dilli Bhurtel from UnityPoint Pediatric Cardiology. If you have a topic you'd like to suggest for the COVID-19 pandemic, please shoot us an email at stlukescr@unitypoint.org. In the meantime, wash your hands, cover your cough, and confine yourself if you're ill, and practice social distancing.